Hi, I'm Dr. Shruthi, Senior Consultant Radiologist at Apollo Hospitals, Bangalore. We are here for a quick discussion of an interesting case. So initially, we'll be discussing the CT scan findings, move on to the clinical radiological discussion, and finally, we conclude with learning points. So truly honored to be having this discussion with our esteemed and distinguished pulmonologist, Dr. Ravindra Mehta, whose work has made a remarkable impact in the field of pulmonary medicine. He's the leading voice in pulmonary health, and he's based at Vaayu Respiratory Care and Apollo Hospitals at Bangalore. So let's quickly go ahead with the case, and he'll just explain us the clinical findings as well.
Yes. So hi, Shruti, and it's lovely to be doing this on this platform. If you remember, we did this interactively for more than 2,000 people online as part of a chest radiology and clinical initiative. And it's nice to take these brief little quirks where we present challenging situations and give some good take-home insight.
So this patient is actually a known diabetic and hypertensive with chronic kidney disease. So she kind of presented to the emergency department with fever, breathlessness, and diabetic ketoacidosis. So these symptoms were quite rapidly progressive, and these are very classic red flags. And this is the CT scan of the patient being played here. These are the lung window images of the CT chest. We see a very striking feature in the right upper lobe, actually, what we call as the reverse halo sign, which is basically an area of ground glass opacification surrounded by a ring of consolidation. Incidentally, there's a lot of bronchiolitis features as well in the background lung, as represented by bronchial wall thickening, central lobular nodules, as well as tree in bud opacities. So this is the area of reverse halo sign that we notice here. The GGO surrounded by consolidation. Similar area we can actually appreciate even in the right lower lobe as well. And also, incidentally, we also notice that there's mild bilateral pleural effusion. So considering all these findings, this reverse halo sign is very frequently associated with invasive fungal pneumonia in an immunocompromised patient, especially pulmonary mucormycosis. There are, of course, a lot of differential diagnosis CT-wise, including OP and TB, as well as sarcoidosis. So, Dr.
So
Mehta,
right.
how
So
would
I
you
think
like to
to
go ahead with this case, and how would you like to manage this kind of case?
Absolutely. So, Shruti, I think this was fascinating, and the radiology was very presented in exquisite detail. In such a situation, our clinical suspicion hovers around what you just mentioned, and top of the list is going to be invasive fungal disease. Now, as a quick background, fungus has come to center stage, I think, in the last few years with with the juggernaut of immunosuppression, transplant, uncontrolled diabetes, multimorbidity, including kidney disease, and of course, the infamous COVID-19, where we learned a lot. So in this case, the reverse halo sign, which you so nicely outlined, probably represents mucormycosis. But as we say, the proof of the pudding lies in the eating. So we have to go and make a diagnosis. Now, classically, if the patient is able to cough phlegm, that's fine. But if the sickness levels are high, the stakes are high, we often start empirical therapy. But in modern times, in 2026, we want to make sure we have proof. So we do bronchoscopy, which is what we are good at, and we are all intervention pulmonologists who are even skilled at taking complex patients. So in this patient, bronchoscopy, along with not only a lavage, because the lavage will only give you so much, but also a biopsy from that area to show tissue invasion would be important. So this patient went through an expedited bronchoscopy in an intervention pulmonary suite, where both the lavage and the biopsy were suggestive of invasive fungus. We have mucormycosis which showed up, and there was also aspergillosis. So here is where it gets sometimes complex and you can get two. But mucormycosis was present in the tissue, so the diagnosis came down to majorly invasive mucormycosis and maybe coexisting aspergillosis. So this was the ultimate diagnosis. Again, to continue, the patient was put on appropriate therapy. Mucormycosis is challenging, is tough, and requires long-term therapy. He was put on intravenous amphotericin, and treatment was continued with careful monitoring for issues. But I have a question for you. As a clinician, we often are concerned that mucormycosis is angio-invasive, and we are worried that despite all the good work we do, there'll be a sudden bout of hemoptysis because of angio-invasion, and that could be both either causing morbidity, intensive care, or may even be fatal. How in a CT scan would you look at that, and what tips would you give the clinician?
Actually, there are quite a limited data comparing the CT findings of all these organisms to differentiate between aspergillosis and mucormycosis. Very few of the recent data actually suggests that this kind of reverse halo sign and pleural effusion kind of goes more in favor of mucormycosis rather than aspergillosis. That's what the radiological findings should always be interpreted considering the host risk factors. This is where radiology and pulmonology can actually truly intersect, and with imaging, some of the imaging features actually guiding clinical diagnosis. But ultimately, histopathology will be the king.
Right. But what about angio invasion? We are worried about angio invasion. So can you comment on that in the scan? Is that possible to talk about?
This is actually a plain scan. I think angioinvasion requires a contrast CT where we can actually appreciate some kind of pseudoaneurysm or vascular occlusion sign, which goes more in favor of angioinvasion. So this was
Right.
a study which was done as a plain contrast, plain scan.
Right. So in follow-up, the patient was put on appropriate antifungals. He got much better. It was touch and go. And the other most important thing is we look for control or reversal of the immunosuppression which perpetuated this. In this case, that is control of diabetes, which is very important. Of course, serology and other things were done to make sure there is nothing else. We went into detailed history for steroids and other risk factors that was not there. So good control of diabetes, appropriate antifungal therapy, a careful watch for complications, a long course compared to the usual infection led to significant resolution. So thank you very much. And as we have seen, a good understanding between the two specialties is very key to try and make sure that you arrive at the right diagnosis in current times where a good pretest probability, a well done CT scan, and appropriate tissue diagnosis accordingly with good follow-up therapy is the key to having a good outcome. Thank you.
Disciplinary team discussions are definitely life-saving, which actually kind of aids in early diagnosis, early treatment, as well as coordinated care. So pulmonary mucormycosis is quite aggressive. So early radiological detection, as well as multidisciplinary action is very useful. So hope to continue with such discussions in future with more real-world cases. Stay connected for more and appreciate everyone for tuning in. Thank you.
Thank you.